Very good afternoon, everyone. I'm Dr. Ashok Sharma, currently pursuing my master's in health management from IHMI University. I would like to welcome you all to the consultation on making India a bilateral corneal blindness backlog free country. On the occasion of National Eye Donation organized by Strategic Institute for Public Health, Education and Research and supported by ECHO India. I would like to introduce Mr. Arun Verma, Director Operations Finance, Sipher, to deliver the welcome address.
Thank you, Dr. Ashita. Good afternoon, everyone who has joined so far. On this occasion of the National Eye Donation Fortnight 2024, it is my great pleasure to welcome you to this significant online national consultation on making India a bilateral corneal blindness backlog free country. Today, we gather here with a shared vision and a collective commitment to address one of the most pressing public health challenges in our nation. As you all know, corneal blindness affects millions of individuals, affecting their quality of life and limiting their potential. Our mission is clear: to eliminate the backlog of the bilateral corneal blindness and restore sight to those who need it. It requires the collaboration and dedication of all stakeholders, including healthcare professionals, policymakers, non-government organizations, and the community at large. I would like to extend a very warm welcome to and my heartfelt gratitude on behalf of our organizer to our distinguished and highly decorated Chief Guest, Major General Prof.Atul, who is an Executive Director, National Health System Resource Center, Government of India, conferred with the Seva Medal and Vishi Seva Medal. The distinguished guest of honor, Dr. Anil Kumar, Director of the eminent Professor Dr. Radhika Tandon, Rajinder Prasad Center, AIMS, Delhi. I also extend a very warm welcome to our experts and the resource person of today, Professor Dr. V. Rajshekhar, who is the consultant at Safdarjung Hospital and Assistant Commissioner, NPCBVI, Ministry of Health and Family Welfare, Dr. Ashok Sharma, Director, Cornea Centre, Professor Dr. Shakeen Singh, HOD, Ophthalmology, SGRD Medical College, Amritsar. I also welcome our President, Dr. Rakesh Gupta, Sipher, Mr. Rajiv Chaudhary, Program Coordinator from Department of Corneal Medicine, School of Public Health, PJMR, Dr. Ashita, and as well all our esteemed participants. Today's consultation will be focused on several key issues like current status and challenges, innovative solutions, policy and advocacy, partnership, and collaboration. As we embark on this journey together, let us remember that every step we take brings us closer to the future, where no one in India suffers from the preventable corneal blindness. Our collective efforts can transform lives, restore hope, and build a brighter future for all. Thank you all for your commitment and participation. I look forward to the productive and inspiring consultation with this from each and everyone. And now, Dr. Rakesh Gupta, who will be giving us the objective of the consultation before we request the keynote speaker. Dr. Rakesh Gupta.
Yeah. So National Eye Donation Fortnight, as we all know, is observed every year from August 25th to September 8th. So this fortnight is dedicated to raising awareness about the blindness, promoting the life-changing impact of the eye donations, and urging more people to contribute to the gift of honor. So education, this is through education and advocacy fortnight that aims to inspire communities to understand the profound difference that can make by pledging their eyes and supporting those in need of the vision restoration. Eye donation theme this year is the theme for it is I Can See Clearly Now, which mainly highlights the result of the eye donation. So Eye Donation Fortnight 2024 is an opportunity to recognize the importance of eye donation and take action to help those affected by the corneal blindness. By understanding the impact of corneal blindness and pledging your eyes, you can play a crucial role in giving the gift of sight and transforming lives. Let us come together to support the noble cause and ensure that more people can see the world clearly and enjoy quality of life. So we can pledge our eyes by just saying that I give my eyes for the purpose of transplantation, medical research, education. I further direct my next of kin herein, name to execute the gift from after my death. I'll share the link for the online donation of the eyes. So the objective of our consultation on bilateral corneal blindness backlog free India, there are around 1,20,000 corneal blind people in India, and 25,000 to 30,000 are added annually. Our backlog that keeps on increasing. Our country as a whole can perform 28,000. This is far below the national requirement. We can perform due to irreparable damage to the tissue. By leveraging global best practices with the leading eye banks and the keratoplasty centers in India. Keynote speaker today is Dr. Radhika Tandon. She's MD, DNB, FRC Ophthalmology, Chairperson National Eye Bank. She was a formal chairperson, I think. She is AIMS Chairperson, Low Vision Aid Services, RPC, immediately past President, Eye Bank Association of India. Dr. Tandon is currently working as Professor of Ophthalmology, and she's head of Cornea, Cataract and Refractive Surgery, Ocular Oncology, and Low Vision Services units at Dr. Rajendra Prasad Center for Ophthalmic Sciences, AIMS. Doctor's research interest areas include cornea, eye banking, stem cell culture, pediatric ophthalmology, epidemiology, and genetics of eye diseases, keratoprosthesis, and bioengineering. Dr. Tandon has been honored with the President of India's Silver Medal, Gold Medal by Royal College of Surgeons at Edinburgh, also awarded a Commonwealth Fellowship to study keratoprosthesis, eye banking, stem cell culture, and inflammatory eye diseases in Sussex Eye Hospital and Cornea Plastic Unit, East Greenstead and Moorfields Eye Hospital, London. And I may also tell you that Dr. Radhika Tandon was instrumental in making Punjab a corneal blindness backlog-free state. That was way back in 1516. And she'll also guide us now how to do it all over India, in all the states and within territories. So over to Dr. Radhika Tandon. Dr. Radhika Tandon, you can share your slides.
Yes. Yeah. Good afternoon, Dr. Rakesh. And just want to confirm that the slides are visible. Are the slides visible?
Yeah, yes. The slides are visible, but it is not in slideshow mode.
Okay, I'll just do it again. Sorry, 1 second.
But we can do with the slide mode also, if you want.
Let me just try once more.
Okay.
Please see, are they slideshow now?
It's not still in, it is not in slideshow mode, but we are okay with
all right. So first, just to begin, I would like to congratulate Dr. Rakesh and the Sipher team for having organized this very important national consultation, and for having very esteemed members of the NOTO and NPCBVI, Dr. Rajshekar, Dr. Anil, for on board. Now, just a brief background again, if we think back of everything that we have said, one should always remember the history. So where the country has come after so many years, decades, we should not forget the great contribution that Government of India has made for this noble cause. So NPCB was launched in 1976. And it was a unique 100% centrally funded program under the Ministry of Health and Family Welfare, Government of India. And the goal was to reduce the incidence of blindness to 0.3%. So if you see 1976, the estimate was 1.4%. And now over the years, it has been reducing steadily. So in the 2001 survey, it was 1.1%, 2006 survey, it was down to 1%. And then there were some course corrective measures taken 2016,
slide is not
17.
moving.
No,
Okay,
I
okay.
haven't moved it. Are you seeing the one where all 1976 and all is visible? Or are you still seeing only the title
Only the title
slide?
slide.
Okay, then I think Dr. Rakesh should share it from your side if you can. Because I don't know why it is not moving. In my computer, it is.
Dr. Rakesh, you're
Please
muted.
stop sharing. Please stop sharing.
Dr. Rakesh, I'll stop sharing and we'll start from the beginning again. Or should I do it without slideshow mode?
No, you can do it. Yeah, you can do it without. But I've asked my person to do it. So you can just keep on talking.
Okay.
Yeah.
Let me go back once and just see again, tab tak, if it's happening. Just see, is it visible now?
Yes.
Yeah, it is visible. Yeah, it is visible. And in fact, it is in slideshow mode.
It is in slideshow mode? Okay, once.
Yeah.
I have to go back one second. Now, can you see this?
Yeah.
So this
We can see this. Yeah. Thank you.
In 2016-17, there was course correction. It was renamed as National Program for Control of Blindness and Visual Impairment, 2017. Along with this, another key decision was taken to realign the nomenclature of blindness as per the WHO criteria. So one thing we should bear in mind, and we should also give some thought to the visionaries who started it in 1976, that India had a very good concept actually of economic blindness. So they had considered that anything less than 6/60 was considered as economic blindness. Then there was social blindness, that is less than 3/60, and there was complete blindness if there was no PL. So sometimes I feel that in our country, the visionaries are there. They truly understand the problem. Sometimes it happens that globally people have their own concepts and they overrule us. So we had to realign to the WHO concept of less than 3/60 as being blindness. But one should think back and realize that this concept of less than 6/60 economic blindness and less than 3/60 social blindness, as an ophthalmologist and a clinician, this is very apt, because when a person has a vision less than 3/60, they are restricted in a certain way, and people who are less than 3/60 are restricted in a certain way. So from that point of view, they had this projection in 1976. One thing I would like you to bear in mind, that when it became NPCB VI 2017, that also was necessary to align with the nomenclature which was being used all over the world, which was the WHO definition that blindness is vision in the better eye less than 3/60. So whatever statistics we were providing, it was not aligning what was there in other countries and for comparison. So therefore, we had to realign. So this is a little bit confusing. That is currently what our figures of blindness is, that we've come to less than, we've come to say 0.31 or 32%. This is now the WHO definition. But if you see in 1.4% in 1976, what they had thought, that was from the point of view of less than 6/60. Now, this is another important thing that we all, since we have policymakers on board, we must keep in mind that it always affects the resources. There's a lot of difference between a certain value and a certain value, and how the resources are distributed or given priority. So I feel that we should use the same nomenclature of less than 6/60 is considered as severe visual impairment, but in brackets, we should have an explanation that this is economic blindness, and we must target that this also is a priority area to be covered. Now, the very, very important contribution is this National Blindness and Visual Impairment Survey of India, which was commissioned by the National Program for Control of Blindness and Visual Impairment and carried out with the support and entirely the team from the Community Ophthalmology at RP Center, AIMS. Now, this is a very good document because it gives you the proper, accurate benchmarks. Now, it's not possible in this for all the nitty-gritty of this document, but I want to explain that firstly here the major cause of blindness, please see, corneal opacity is a second most common cause above the age of 50, and corneal opacity is the most common cause in the younger age group 0 to 49 years. So from this point of view, I appreciate Dr. Rakesh and that they have taken it as a mission mode that we must tackle this problem in a little different way rather than we've come to say 0.31 or 32%. This is now the WHO definition. But if you see in 1.4% in 1976, what they had thought, that was from the point of view of less than 6/60. Now, this is another important thing that we all, since we have policymakers on board, we must keep in mind that it always affects the resources. There's a lot of difference between a certain value and a certain value and how the resources are distributed or given priority. So I feel that we should use the same nomenclature of less than 6/60 is considered as severe visual impairment, but in brackets, we should have an explanation that this is economic blindness, and we must target that this also is a priority area to be covered. Now, the very, very important contribution is this National Blindness and Visual Impairment Survey of India, which was commissioned by the National Program for Control of Blindness and Visual Impairment and carried out with the support and entirely the team from the Community Ophthalmology at RP Center, AIMS. Now, this is a very good document because it gives you the proper, accurate benchmarks. Now, it's not possible in this forum to go over all the nitty-gritty of this document, but I want to explain that firstly here the major cause of blindness, please see, corneal opacity is a second most common cause above the age of 50, and corneal opacity is the most common cause in the younger age group 0 to 49 years. So from this point of view, I appreciate Dr. Rakesh and the Sipher team that they have taken it as a mission mode that we must tackle this problem in a little different way rather than the traditional method. So, as I said, this is an actual survey which has been done, and it is using the concept of the rapid assessment of avoidable blindness platform, where the people have gone house to house in the selected cluster concept all over India. But in the 0 to 49 years, it was a little shorter, smaller subgroup which was studied compared to the above 50. And here again, credit to the Community Ophthalmology team at RP Center that they insisted that we must do the entire population. There was, of course, a shortage of resources. Ministry of Health did provide whatever maximum they could, and at least the data has been done, the survey has been done to give you very reliable data. So there is a long journey, definitely. There is corneal blindness. We have to consider that there are the transplants to be done. So we have to have the resources to to perform the transplants. You cannot do transplants unless you have suitable donor tissue. Donor tissue is only going to come when there are donors. And we have to understand that constantly we are talking about high demand, low supply. And it is time that we also question ourselves that why is there such an unhealthy high demand for donor corneas? Why is there such an unhealthy state of the corneas in our country from totally preventable causes such as trauma and infection? If you see all the statistics, the largest bulk of people who are requiring the keratoplasty are the people who are affected by trauma and infection in the younger age group, and in the later age group, they are due to complications of cataract surgery. So these three things are totally within our control. We must take that into account and we must control that. Simultaneously, then we should have the subset of people who are left who are going to require the keratoplasty. And we should, if we build up our resources, we can totally eliminate this problem within a few years. Now coming to this concept. So therefore, Eye bankers and corneal keratorefractive surgeons can take care of the corneal blindness. This is on one side, the hospitals and eye banks. But the best part about today's webinar is it is not only restricted to the confines of hospitals and eye banks, because this work cannot be done by only doctors and technicians. It requires the full cooperation of the public, the community, and it is the NGOs and the welfare, well-meaning people in the public who are the very key connection between the hospitals and the patients. So therefore, we have the public, we have to have healthcare providers, of course, and their communities. And we are very, very grateful to all the NGOs who are going out of their way to do this at a personal level. Now, as I mentioned earlier, NPCB originally was 100% government funded. And over time, they started also supporting NGOs because it was found that it is impossible for government to cover everything. So they started supporting NGOs and other partner agencies to assist in the program. So therefore, there was a concept of the dispersal of funds. There is some confusion going on for the last several years. I'm not very clear on this, why there has been a sudden drop in the way the support was being given. Either it's some problem on our side that we are not putting our data properly. But for the last 3-4 years, from many places, we are hearing that earlier the support that was easily available for the expenses involved in this activity, which was being supported by the government, there is some gap coming in, and we are not very sure what is the hindrance. So that is something that we should also look at and facilitate. Now, this is the concept that we have, that it is a miracle by dream, mega initiative for eradication of corneal blindness by digitization, re-energization, education, advocacy, and multitasking. This is something that can very easily be done. We have to also look at the corneal blindness and eye banking, look at the data. We've already got that. We have to upgrade and modernize the eye banking services so that even in the distant areas, the proper facilities are there. Many people will tell you that sometimes they do face hurdles. And we have also several publications which says that how one can have a targeted approach or a strategic approach, because ultimately you have to work efficiently. You have to try and get maximum transplantable tissues, and you must make sure that no transplantable tissue or no opportunity is wasted. And post-mortem cases is a very, very good opportunity, because generally the family of these patients or these accident victims, others who are going for post-mortem, they're more receptive to the concept of eye donation, and it is a way where it can be very easily facilitated. The other thing is that we have confirmed that it is equally good to remove only the cornea. You do not need to require the entire globe. This has been very nicely shown, and this is one other publication, one donor cornea for 3 recipients. So we can try to maximize the utilization of the cornea. So there are just a few of our publications. And here another thing, because people are very apprehensive that in post-mortem cases, 6 hours is passed, 8 hours is passed, then what do we do? So we have shown that if it is a good quality mortuary with a neat and clean service, and they are having a proper temperature control system, then if you extend the death retrieval time beyond 6 hours, provided the body is properly refrigerated and the temperature is maintained at the 4 degrees centigrade, these corneas can be very successfully transplanted. So the refrigeration is the key. Now, just a quick experience of the blindness control program in Punjab. So this was 2016. This experience was shared. This was at the Global Alliance of Eye Bank Association Symposium at the Asia Cornea Society meeting. So this was again the fact that we feel that we can eradicate corneal blindness. And the first step, as Dr. Rakesh said, is to remove the bilateral corneal blindness backlog. And we believe that it is possible to eliminate. And the first thing, which is very easy to be done, is to take care about the surgical treatable corneal blindness backlog. And here also it's important, because if you're doing anything, if you're running and running and running and not reaching anywhere, not able to show any result, it can be very discouraging. Whereas if you can put a target and overcome that target, That's something which is at least more encouraging, and at least technically you're reaching somewhere and doing something which can be proved. So therefore, I feel that we need to consider this approach of at least taking care of the bilateral surgically treatable backlog. And it is not to say that you'll be depriving other patients. We can have, once we have the proper data, we will have a proper situation analysis, and then we can decide what to do. Now, firstly, I'd like to appreciate the concept of Madam Vinny Mahajan, who was then the Principal Secretary Health in Punjab government. It was her. She's a non-ophthalmologist, non-doctor, but an IS officer, but an excellent administrator. So she had said, look, you people are running and running and you're not showing any targets, you're not achieving any goals. So why don't you set a goal? So she suggested that, look, let's take care of the bilateral backlog. And at that time, Dr. Rakesh was a state program officer, and they were very key people in mobilizing all the resources. My role was as an external expert, as an ophthalmologist and a corneal transplant surgeon, to give the technical advice. But I would have to say that firstly, this can only be achieved with government, full government support, but not alone. We require partnership with all the stakeholders, and only this model can work. So the deadline was to start in September. 1 month before that, the meeting was held, all the goals were set. The initial target was to operate all the bilaterally corneal blind. So they had to be identified. The population was calculated. It was decided that about 50% may not be treatable. So how many cases are added? The statistics were sort of calculated in a customized manner. And it was decided that we require 3,200 corneas, considering 50% may not be suitable for sight-restoring optical keratoplasty. This itself was a huge exercise, and we have to appreciate the contribution of all the eye banks, all the corneal transplant surgeons, and all the NGOs working in this field, and of course, all the government hospitals of Punjab. And this is how then the campaign started. It started led by example. And then it came to light that there were certain sort of challenges going on. Firstly, the NPCP grant in aid at that time was not going very smoothly, or there were some technical problems or some sort of protocol issues. Total registration fee at that time in Punjab was very high. It was 1.5 lakhs. So this again, on a mission mode, it was revised to 10,000, whether it be government or private. And up to then, the Transplantation of Human Organs and Tissues Act of 2011 and rules had been notified, but had not been adopted by government of Punjab. And this also was done. So you can understand that when there is a will, there is a way, and things can move, because actually it only required proper coordination. Nobody says that they want to stop this activity. It's just a question of the right people connecting everybody and going ahead. Then, of course, the efforts were made, refresher courses, ophthalmic officers were trained for recovery, corneal transplant surgeons were energized. They also contributed a lot. And I must say the surgeons in Punjab are absolutely excellent. They are fully equipped and fully competent in doing the best surgery, all the modern techniques, including endothelial keratoplasty. And then the plan was that patients would be identified. They would go to the nearest ophthalmic center. It would be confirmed if they're feasible for keratoplasty, and then the ophthalmologist would refer to the corneal transplant surgeons, where they would be registered, and then the eye banks would be informed. Then it came to light that yes, it is true that there may not be adequate corneas available locally. So then from other states, from any other neighboring where the cornea was not being utilized, a system was made that the corneas can be shared and can be used. So all the corneas that were transplanted did not come only from Punjab, they did come from other states as well. And then the visual outcome, this is another thing I would like to mention, that here again, it was good that Madam Vinny Mahajan insisted that, look, you may be doing something, but you must monitor the outcome. So the visual outcome was monitored 3 months, 6 months, and 1 year, and the records were all updated. These high-level meetings were held periodically. As I said, September 2015, it was launched, and then twice a year, the meetings used to be held. And over time, each time it was found that how many bilateral cases, they were given a priority, but that didn't mean that the unilateral cases were denied surgery. And also sometimes the patients either didn't want surgery or they were not well enough. They had some other systemic problems. So from time to time, the list kept on being updated, and it was a huge effort. It is not at all easy. It is a huge task, but it can be done with proper coordination. No doubt it's a commendable effort. It's an excellent teamwork. It's a good beginning and a leadership role model. And a simplified method, I will say, we can follow nationally. Every state will not have the way the motivated team was there from Punjab government at that time. But for nationally, I feel it is not at all difficult for us to ask all the quota registered eye banks and corneal transplant center to simply submit their data in terms of numbers. Nobody is asking ki kaun sa patient hai, kahan hai, etc. We just want to know ki falane keratoplasty center mein kitne patients registered hai, 20, 30, 40, whatever it is. And that is, they are all registered under THOTA all over the country. So all the THOTA regulatory authorities simply have to submit that what are the numbers. And I think Noto is the right platform to collect this data in a simplified manner. The moment you tell them ki aap, upload karo each and every patient ka data, that won't work for ophthalmology because cornea is a tissue and the numbers are very large and the system in Noto is a little bit complicated. So they will find it a big burden ki each patient ka upload karo. That is not at all necessary. Simply we can say, bhai, as a shortcut, you just send us आपके कितने waiting है. Within a month, we'll come to know कि कितने actual status है. At least approximately पता चलेगा. So we will have an idea and then we can make a roadmap forward. This level of detail of data we are not going to be able to get. But once again, I would like to show कितना motivation था Punjab का and कितना, it was amazing. It was so nice to see all this data kept coming in. Dr. Rakesh would personally get it updated, follow up, and his team. And then later, I forget the lady who took over afterwards. So when Dr. Rakesh left, the other lady who took over, she also did a remarkable job. And this is how it was, number of bilateral, and then even the therapeutic keratoplasties were performed. And then you can see what tremendous, beautiful job the surgeons were doing. They were sending their data. This is also in compliance with the idea that we must document the results. And you can see these results are unmatched. Any donor family will be happy that the gift of sight that they have gone has been transplanted into this beautiful jewel gem of a cornea, which is shining in somebody other person's eye. Quickly about RPC and AIMS, we also...
Dr. Radhika, actually, we are running late.
Okay, I'll stop
here. Conclude, yeah.
I'll stop. So as a conclusion, I will say that at the National Eye Bank, we are also committed to this cause. We are always ready, willing, and able to provide whatever support you need. And from policy point of view, also, we are well placed to coordinate with Dr. Rajshekhar and his team and Dr. Anil and his team. So that I feel that if everybody agrees, we can try this model and see if one can come out with something concrete and conclusive very soon. Thank you.
So thank you, Dr. Radhika, for this wonderful presentation and just letting us know that NPCB VI survey 2015 to 2019 that showed that cornealoplasty was the second most common cause more than 50 years age group. And it was the first common cause, the commonest cause of blindness in 0 to 49 age group. And she also shared her own experience and our experience in Punjab for making our state as corneal blindness backlog free. So thanks a lot, Dr. Radhika. So please stay with us for another maybe half an hour, if possible. Yeah, thank you. So now I think we have Dr. Anil with us. So Dr. Anil, do you have a presentation?
No, there is no presentation. I'll be just addressing.
Okay.
I was not knowing I have to make a presentation because I thought
it really doesn't matter. Yeah.
I'll be speaking actually.
Okay. So Dr. Anil is the director of the NOTO. So I don't have that slide. I can't just share that slide with me. Let me see if I can show your slide.
No issue, sir. I'll introduce myself.
No okay. Please introduce yourself. Yeah. Thank you.
Okay. So good afternoon and thanks for inviting me to this very important agenda where we are looking for making India bilateral cornea blind free country. And basically, NOTO is a National Organ and Tissue Transplant Organization. And NOTO has been set up by the central government with a view to establish a network of hospitals which are doing organ and tissue retrieval or transplantation or banking. So it is basically a network between them, and NOTO is at the apex of this network. NOTO is at the apex level of the network, and then NOTO is also the second responsibility which has been given to the NOTO is maintaining the national registry. The national registry of those who require organ or tissue donation or organ or tissue transplantation. So particularly in case of cornea or other tissues also, what we have right now, we don't have a system of organ, like we have system of organ procurement and distribution. That in case of organs, that similar system of tissue procurement or cornea procurement and distribution at the country level. Matlab, there are systems at the individual institution level, or maybe at AIMS level or at the National Eye Bank level. But currently, we don't have a system of national registry that we have in case of organs. So, because most of these eye banks, they are having their own MOUs with the hospitals which are doing either retrieval or they are doing transplantation. So mainly, if you look at the situation, first of all, what are the various issues on which we should focus? First, we should be knowing the current situational analysis very thoroughly. What is our data? How many people are requiring cornea transplant? Because there are variable figures that we get. Like sometimes we say that we have 1/3 of the cornea blind patients in the world. Sometimes we say that we have 1.2 million corneal blind persons in India. That is, I think, RP Center study of 2018. And we estimate around 25,000 to 30,000 people with cornea blindness are added every year. And it is now, as Madam has also told, that less than 50 years, it is the commonest cause of blindness. And in case of more than 50 years, it is the second most common cause. So this is very important. That all this is whatever figures are available, but we don't really have a national level registry for each and every patient who requires cornea transplantation. So that is one gap that I identify. There may be, and there may be certain duplication of data also, because many authorities are maintaining registry. So we also need to look at deduplication of the patients also if it is required. Then we have to know what is our infrastructure. I think we estimate around 1,000 cornea transplant surgeons in the country, but how many of them are actually doing cornea transplantation? Because we have a requirement of post PG 3 months, training in the cornea transplant operations in a recognized hospital or institution. So how many of such doctors which are trained in keratoplastic surgeries are available in the country? And then the equipment, the infrastructure, the registered centers. So that information also has to be available at national level. So that needs to be compiled at the national level. To basically, this is required to have an efficient and system of tissue procurement and distribution all over the country. Then, so this is one. So I am trying to highlight the data gaps. So data gaps can be, these gaps in data, they can be covered up, like they can be covered, by having a system of registry of the patients and registry of the patients can be done by the hospitals wherever they are seeking treatment. Noto can give them a login ID and password. The hospitals can register them with the Noto. That registration facility is still available with Noto, and so we want every hospital which is doing keratoplasty, which has the registered patient with them, they should be listed with the national registry, so that we know that hospital-wise how many patients are there, state-wise how many patients are there, and nationally how many patient backlog is there, so that we are able to plan very concretely that this is the action which is required. So first step which is required is to have a national registry of individuals which have cornea blindness and which are treatable with corneal transplantation. So that is the one thing. Second, then once we have, so they will be like each one will be having a Noto ID, and which will be Aadhaar authenticated. And once we, and then we, so this, besides that, we have the assessment of the infrastructure, the corneal surgeons, and all those hospitals which are doing cornea transplantation. So that is another important assessment that we have to have. After the assessment, we need to have these these infrastructural assessment. Then if it is required, we should take steps to do the capacity building. Capacity building, what I believe is required in for two purposes. One, we can have a like a refresher course or a short-term training and certification of the ophthalmic surgeons. And it can be done in coordination with the National Program for Control of Blindness and VI for certification of the ophthalmic surgeons which can do cornea transplantation. Then second training which is required is in the corneal retrieval. So cornea retrieval or the eye retrieval, and we now, as we all know, doctors as well as technicians, they are now authorized to do eye retrieval. So their training responsibility has to be taken by the, again, I will say, by the program of control of blindness, and so that we know that we have the trained and their training as well as certification, that these people are trained to do the eye excision and eye retrieval and cornea excision efficiently. So, and once we have these capacity building plan in place, the infrastructure in place, the registry in place, then we can, then we can plan our, this thing and area wise. And then perhaps we may have to make certain legislative changes where we permit anyone who has expressed his desire to donate cornea, and in case of particularly institutional deaths, if it can be, cornea can be permitted to be removed from every institutional death, because these corneas are not required for any medical legal purpose. These corneas are also not required, mostly are not required for any medical legal purpose, are also, if have proper counseling or proper consent in advance, because I have shared one video with you where people have pledged to register their organ as well as tissue, and and it was launched last year, this separate registry of the people who want to donate their organ and tissues after death. So last year on the Prime Minister's birthday, this was launched on 17th September. And till now, we have 1.83 people have pledged to register, including cornea register, pledged to donate their organ as well as corneas after death. So that is also very important, that we can run these campaigns, and we can bring a legislation where cornea retrieval is permissible even without consent of the family member in case of institutional deaths. particularly, then perhaps we will have a good number of corneas to be, or even if we can announce, and then the family should agree that, like everyone, where in case of institutional death, the family would be requested for cornea donation. So even if this kind of announcement can come from the highest level of the highest political level, then it can help. So so this is the basically my take on this, that we should have and then we have a cornea allocation policy which is available on the NOTO website, which was drafted in consultation with the experts, like how the cornea will be distributed. Definitely it will be distributed first locally to the hospital, then within a state, then within the country or region. We have a regional level also under the organ, and then it can be distributed at the national and even if right now international patients we have not allowed for cornea distribution, but cornea allocation policy is there on the NOTO website that can be gone through. And so in a way, for future, what we should look for, we should register every patient who requires cornea transplantation, and we should increase our advocacy and awareness for cornea donation. We should provide an efficient and effective system for cornea collection and distribution to the waiting patients, because it should not be that somebody gets a cornea and we should have, even if there are, priority criteria, that should also be, well defined, so that those who require on priority can be catered to. So this is in nutshell, and we should also be knowing that we do not require any license to do cornea retrieval. Any hospital or retrieval team can do cornea retrieval. For cornea retrieval, license is not required. For cornea transplantation and eye banking, license is required. So whenever we are registering eye bank, they should be asked to declare all their cornea donation centers or cornea or cornea retrieval teams, and they would be responsible for maintenance of standards of these cornea donation centers or retrieval teams. So it should be the responsibility of particular eye bank that they will ensure that particular retrieval team or the eye donation center is adhering to the standards as are defined under the Transplant Act. So because we are not advocating for separate license for cornea retrieval center. Similarly, if it is these retrieval centers are associated with a medical college or a registered cornea transplant centers, so there also it is the responsibility of that particular medical college or transplant centers to ensure that they adhere to those standards. So all these steps, if implemented, in toto, can bring in, an efficient system of cornea. We don't want that anyone, it should not be just a MOU between a hospital and an eye bank, and they are doing it with each other. It should be very transparent. It should be very, in the knowledge of the authorities, that how the cornea is being collected, who is getting it, and it is not being favored. The people are not being favored for cornea allocation. So all that transparency has to be brought in the cornea allocation system also. So that is all I had to say. And if you have time, sir, you can play that video of 1 minute, which is basically to help people to register their wish to donate organ and tissue after death. That is combined. It is not specifically for cornea. And the website is very simple, noto.ebdm.gov.in. So thank you so much. I'm open to any questions if there are.
Yeah. So thank you, Dr. Anil. So we don't have any, you have given very valid ideas for the recommendations. And I'll request you to, I'll send the draft recommendations and you can add to it. So you suggested that we don't have a national registry and we need to look at the deduplication of the data. And the infrastructure, we have about 1,000 cornea surgeons, and many of them may not be doing active surgery. And if we give them some capacity building 3 months course, then they may start doing surgeries. And then we also need to look at the equipment in the keratoplasty centers, even the government and the private as well. And the keratoplasty hospital can register with the NOTO. So that is a good idea. And we need to do capacity building for the cornea retrieval and for the cornea surgeon. So thank you, Dr. Anil, for the wonderful suggestions. And I'll just share with you the draft suggestions, the draft recommendations, and please put your own suggestions into it. So thank you. Thanks a lot, sir. Thank you.
Thank you, sir. Thank you.
So now we have our chief guest with us. He is Major General Professor Atul Kotwal. He is a Seva Medal and Vashi Seva Medal. He is Executive Director of National Health System Corporation System Resource Center of Government of India. He is from AFMC Pune. His MD in PSM. He did it in 1991. Then he did postdoctoral fellowship epidemiology in 2001, 2004. And he's a WHO fellow, Advancing Monitoring and Evaluation, Newer Advances in Healthcare Systems, Royal Tropical Institute of Netherlands. He's a medical professional, public health researcher, administrator, educator, mentor, advisor, and a teacher with significant contributions in the field of public health and epidemiology for more than 39 years. He worked in Planning Commission, Government of India, and Government of Botswana as well. And his key appointments have been Professor of AFMC and Army Hospital Research RR Center. Then he is Professor and he was Professor and Head ACMS, DDG Disability Pensions and Office of DGA, AFMC MOD. So, and moreover, he has received numerous awards for contribution to the armed.
I think we could.
Okay.
Thank you.
So they can read themselves, yeah. They can read themselves.
Sorry interrupting, sir, but thank you very much for that introduction.
It's
Thank you,
okay,
sir. I think we saved time.
Okay.
And it's just that I was feeling odd interrupting you, but thank you.
You are welcome, sir. You are welcome.
So thank you, Dr. Rakesh, sir, and a very nice, listening to the talk by Dr. Radhika Tandon and also to Dr. Anil Kumar, who DDG, looking after the entire program. I must at the outset congratulate Sipher entire team for organizing this very important webinar on a very important topic, and also ECHO to collaborate with them. All the epidemiology and also the current situation and also a little bit of way forward also has been covered by the speakers. So I'll be brief. But then I would just like to highlight that even though it is way behind the cataract as such, cataract-related blindness, but it primarily affects a younger population, and this disability-assisted life as compared with the cataract blindness are much, much greater. So that's, I think, the importance of the corneal blindness as such. And being a preventive medicine specialist, I thought whenever we talk of strengthening our system for the corneal transplant, we also should talk about how to prevent it. So we all know the causes, various infections and all, or vitamin deficiency, which was the older cause as such, poor nutrition at birth, infected ocular abrasions from agriculture work or even industrial work, injuries due to lack of protective glasses, protective equipment, and of course, few congenital diseases as such. So we need to prevent load decreases. Secondly, I would like to also highlight that there's a new initiative now, Ayushman Arogya Mandir, the Ayushman Health and Wellness Centers under Ayushman Bharat program. We need to leverage that Ayushman Arogya Mandir. We have 5 new packages of services, and one of the packages is the ocular health as such. So that I think needs to be leveraged from very beginning, as from the grassroots level. How we can talk about when we talk of IEC and BCC as such. So the programmatic issues are the main. I'll quickly just like to share 10, 11 points about the way forward as such. As rightly mentioned by Dr. Anil Kumar, create a registry. That I think is required to know the burden. And the NOTOs, the ROTO and SOTOs, they can facilitate this this registry, and also subsequently it will help them in facilitating the efficient tissue transportation and allocation also. That's, I think, what is required immediately. It will also help them in assessing the need as such, and have a live registry as such, which is there. These blind registers need to be updated regularly, and now with the in a digital era, all that will be in real time basis almost. And establish cornea units as such, or the government medical colleges should have dedicated cornea units. We can also do an advocacy with the government that all the new permissions for the medical colleges, or even when they register for their PG seats after fulfilling the UG requirements, they must be asked to create these units as such in the college. So operational eye banks need to be ensured, and the cornea collection sites. That's, I think, another in the institutes as well as the colleges and the entire network. Even the collection should be permitted, as such, which is there, but then needs to be increased as such from the crematorium sites and the burial sites and all. Facilitating transportation by all airlines and other modes of transport as such, free of cost. And ethics, of course, even though when we talk of all these expanding all that, so ethics need to be mentioned, as Dr. Anil was mentioning that all institutional deaths, but ethics need to be kept in place, to be given due importance about the voluntarism. And we also know the rule in our country as such all over the world that even someone is voluntary, it's volunteers is organ donor is the next of kin finally after the death, who is the final authority. So that, I think, needs to be addressed with a strong information education communication and behavior change communication. So that's where I think somewhere we need to reach the religious barrier also, and also various other ethnic and other social taboos and issues which are associated with the organ donation on a whole, and even cornea as such. The management again needs to be optimal help in this. The surgeon workforce as such, of course, we're talking of public-private partnership also, but even the government setup as such, what we have now done under NHM, that the specialist cadre has now been created as part of the public health management cadre. The states have been given various options, and few states are utilizing it also. You quote, we pay. So states need to fulfill all the vacancies as per the Indian Public Health Standards, IPHS 2022, at the district hospital level, and so that the eye surgeons and all are there, which will be made part as desirable in the smaller ones and essential in the larger ones, hospitals as such. So those needs to be fulfilled, and the amount of pay is not an issue. States have been given that leverage with that kind of flexibility as such. Training of ophthalmologists in the task shifting approach, instead of a 3-month course, I think it should be reduced to 1.5 to 2 months course. I think 6 to 8 weeks, because after all, we are training the ophthalmologists who already MS ophthalmology. So it's just by teaching them fine nuances of the corneal transplant, which needs to be there, and we need to make sure that during their MS opthal, this is also covered in their curriculum as such, and there's a dedicated record of that during their MS ophthalmology, that they have undergone an exposure, or they have assisted in something, and if they have not, then at least at 6 to 8 weeks course, that will reduce the time. It will also increase the uptake also of this, and world over, the task shifting approaches are now be taking over. The encouraging donation linkage with the licenses, even Aadhaar ID and Aadhaar, that also can be thought about and discussed. That could be linked with at that time only, and of course all the insurance and all, intersectoral collaboration and all, the teleophthalmology integration, and also monitoring of the services. The best practices of the states and UTs, like the Punjab experiment example as such of the bilateral corneal free in 2015-16. That's, I think, now needs to be propagated to all the other states. One of the states is also giving more money as such per surgery as compared to the other state. That also needs to be disseminated. So I think it's an excellent initiative for this webinar, and the discussions here and some kind of summary here could be then circulated, could be made available to the wide public, and also shared. Dr. Anil Kumar is here, which who can convey in various meetings in the ministry to strengthen this program as such, and will also affect the not only the corneal as such, it will affect the entire organ transplant program also as such. So I think with that, I'll stop here. But again, thank you very much for the invitation. It's been a learning for me after listening to the experts and also the DDG of the program. Thank you very much, and wish you all the very best.
So thank you, Dr. Atul Kotwal, for joining us as a chief guest, though you were a little hesitant about the topic. But I told you that public health people, they have to deal with all the topics. And I think it's a good suggestion that we must leverage the Ayushman Arogya Mandir because ocular health is already included in it. So I'll also share the recommendations and you can add some suggestions to it. So the way forward, you told that we have to create registry, need of the tissues, then blind register need to be updated. And the cornea units, they need to be compulsorily made in medical college. So that Indian Medical Commission, that has to take note of it. So thanks a lot, Dr. Atul, for joining. And you were traveling. I know that it is difficult to join when you are traveling, but thanks a lot. Thank you.
Thank you very much. All the
Oh,
best.
thank you. So now we have with us Dr. V. Rajshekhar. So, Mr. Arun Verma, you can introduce him,
Thank you so
please.
much. Thank you, Dr. Rakesh, and thank you to our chief guest. Now we move to the technical session, part of the online consultation. So we have with us the experts and resource persons, and the first expert with us is Professor Dr. V. Rajshekhar, who is a consultant at Safdarjung Hospital and Assistant Commissioner, National Program Corneal Blindness and Vision. With the Ministry of Health and Family Welfare, we don't have a complete, resume or the biodata of the CV of the Dr. V. Rajshekhar. He'll be speaking on the provision under the NPCV to promote eye banking and the AP surgery and the report of the Government of India 2023-2024. So over to Dr. V. Rajshekhar.
So, Dr. Rajshekhar, you can present yourself. You have been made co-host.
Okay, so can I share the screen now?
Yeah, sure.
Yeah.
But that option is not coming. Just a second. Yeah.
Is it? Yeah.
Now
Yeah, we
it's
can
coming.
see it. We can see the presentation.
Yes.
Just make it like in slideshow mode.
Slideshow, I'm doing it. So, good afternoon, everybody. And it's both an honor and a privilege to be before you and as we gather to celebrate this occasion of eye donation fortnight, which is a very noble cause. With this, I would like to highlight the basic statistics which our blindness control program is collecting, and what are the initiatives which we are doing towards the corneal blindness.
Can you make it
Yeah.
slideshow mode?
I think it is on slideshow mode.
Okay, doesn't matter, but you can just try to move the slides.
Yeah. Is it moving?
No,
It's not moving. Yeah. Can you stop sharing and do it again? Yeah, now it is moving. Yeah. So we can see the introductory slide.
Yeah. So the primary focus of the blindness control program is on the prevention of the common causes of blindness, which I need to mention cataract is the most common, and the other visual impairments like refractive errors, which is the second commonest cause, which is a second commonest cause of avoidable blindness. Then third is again the corneal blindness. As per the latest survey reports also, we have realized corneal blindness has come up in the statistics, and with these the other conditions which we address are diabetic retinopathy, glaucoma, retinopathy of prematurity, and other activities like manpower, equipment, many other aspects are there in the blindness control program. So with this, I would like to mention is one point which we have taken up as a mission mode is the cataract surgery campaign, which is the Netra Jyoti Abhiyan, in which we are focusing mainly on cataract surgery backlogs, and we wanted to declare India as a cataract backlog free by delivering a national target of these figures, that is 75 lakhs, then subsequently 90 lakh, 105 lakh for the years 22-2025. Now let's come to the corneal blindness, which is the magnitude, and we all know these technical details. We have something called a full thickness keratoplasty and lamellar keratoplasty. Here, I would like to mention that we cannot, we can have the maybe the exact numbers of what is the burden in our country, but the good news is that we can actually address all the blindness which is there with a lesser number of corneas, because which a single cornea can be used in more number of eyes. We have this pyramidal structure of eye banks and our eye donation centers and the training centers. In this pyramid, what we need to understand is we have a huge number of eye banks which are being registered, and these eye banks, we have almost more than 700 eye banks which are registered in our country, but the functional are around 200. So this gap is one which we need to address, and the answer is not making more number of eye banks, but we need to improve the collections per eye bank, and secondly, the number of trained surgeons who would be available for the corneal surgeries. So we all know these are the basic causes for corneal blindness in India, which is still the nutritional deficiencies, vitamin A deficiency, measles, trachoma. When we go to the field, these are the most common causes for causing corneal blindness, and we need to also address this quack therapy is because many of the over-the-counter medications which are being given are steroids, and they damage the cornea irretrievably. So our aim should be to prevent new occurrence of new cases, and treat the existing by these various methods of keratoplasty and others. And blindness control program has been training eye surgeons since the day this program has been started, and now the numbers are almost 500 to 600 surgeons per year. But the and we have a specific training program of 3 months, which is as per the mandate of our NOTO guidelines, that we need to have 3 month training for a eye surgeon so that he can perform keratoplasty. Despite that, we have less number of surgeons coming forward to take up this uh, training. So that is one thing which we need to either make it a mandatory part for all the eye surgeons, or uh, somehow this particular gap needs to be filled up. As far as though we are willing to offer training, the number of surgeons coming forward are less for specifically corneal transplantation. Then we also need to have some eye donation counselors, or we can call them grief counselors, which we used to call them earlier. And we need to train specific eye bank technicians who are also involved in corneal harvesting. So for this, we have a specific course also identified institutes, and we do send them through the state, whoever wants to get a training or a refresher training, and this is an ongoing activity of our program, and specific funds are allotted for this. And we also have an IEC expert at the central level for awareness, for creating awareness for eye donation and many other activities of our program. And we have IEC experts at the state level in the blindness control. So we do create awareness through multimedia, newspapers, radio, television ads, in fact, hoardings, posters. We send SMSs to the mobile phones, and also conduct rallies. Uh, we also offer training for ophthalmologists, eye donation counselors, and other paramedics. So Now, regarding the documentation, as for the THOA Act 2014, we need to do these tests and all before the corneal transplantation. At times, it becomes a challenge to get it done and finally get it transplanted in time. So, these the awareness that this cornea has to be transplanted within the period of 8 hours it becomes a challenge, especially in the periphery. And we need to have better storage facilities where we can, and also the medium which we are taking, which only lasts a cornea for 2 hours, to 48 hours. The other financial support which we give is to the strengthening of the eye banks, eye donation centers in the government sector. Then, as I've already told, the eye surgeons. Then support to eye donation counselors is we in fact allocated money for contractual manpower in the states. Individually, whichever state has demanded, we have given so many contractual appointments in that for eye donation counselors. And we also provide funds to RP Center aims to prepare a MK medium which can be provided to all over this MK medium is provided to all over the country. In many institutes they do take them. And I think the other institute which prepares MK medium is LV Prasad Eye Institute and some other center down in the south. And the other initiatives are we have a dedicated helpline that is 1919 for the eye banks. And we have also a toll free number which is there displayed here. And we have been providing financial support to meet the salary of the telecounselors to maintain the helpline of iBanks. And then the other role is registration of the iBanks, accreditation of existing iBanks, and developing of training modules for technical assistants and cost-effective iBanking services in India. So, and another major financial assistance which we have been giving since years is the assistance to the counselor who collects the eyes, 1000 rupees per pair of eyes, and also recurring assistance to the eye banks, that is 2000 per pair of eyes. And a fund allocation for each optical keratoplasty to the cornea unit is around 7500 rupees. For establishment of eye donation center, we pay 1 lakh rupees in the which includes the equipment for transportation, etc., and also maybe a bike which he can and also we for support of iBanks we give 40 lakh rupees to a iBank which is only to be established in a government medical
So,
college.
Dr. Rajshekar, please, sorry for the interruption. Can you just
No, no,
give us the report? Yeah, please give us the report. Dr. Shakeen has to go early. Yeah, thank you. Thank you.
Yeah. So this is the report. This is the achievement which we have got. We have gradually, in fact, there was a dip during this COVID period. That is 2021. We had only 11,000 corneas which were transplanted, but it has gradually peaked to 62,370 in 22-23 and around 65,000 in the 23-24 year. So the way forward is basically we need to make a very good network of eye banks for exchange of donor material, and we need to have transplantation centers almost in all the places so that whatever corneas are being collected in the respective hospitals can be done. The surgeries can be done. That's all. Thank you.
So thank you, Dr. Rajshekar. So you gave very valid suggestions also, and you talked about the common causes of blindness, and then the Netra Jyoti Abhiyan about the cataract surgeries. And you have kept the target of 105 lakhs in 2022-25. And you also showed us the organogram of the eye donation like the eye bank training center, then eye banks, then EDC. So it is really we need to just improve the functioning of the eye banks, because many of the eye banks, they are not functional. And you also told about the common causes of the corneal blindness, and what we need to do. We need to increase the number of eye surgeons, we increase to number of the eye donation, and we also have to look at the quality of the cornea. And the report of 2022 and 23 and 23 and 24, they're very encouraging. So the number of keratoplasty surgeries are increasing. So thanks a lot. So I had to interrupt you because Dr. Shakeen has to go to OT. So Dr. Ashok, if you allow, we'll call Dr. Shakeen first. Thank you.
Yeah, no problem.
Yeah. So can you stop sharing? Dr. Ashok, can you stop sharing, please?
Thank you so much, Dr. Ashok, for a very informative presentation. Now I'll request our other expert, Professor Dr. Singh, who is an head of Department of Ophthalmology at SGRD Medical College, Amritsar. He will be, making a presentation on the report of the Center 2023-24 difficult cases for keratoplasty performed by him and the suggestions for the recommendations. So over to Dr. Shakeen.
Do we have a presentation to share?
Yes.
Okay. Please share it. So you have permission to share, please.
I'm unable to share.
Yeah, it is visible. Yes. Yes, it is visible.
So thank you, Dr. Kesh, for giving this opportunity. And I must congratulate Sipher and the whole team for putting us all together to think on this very important topic of eye donation. A very purposeful lecture has been delivered by Dr. Arun Verma ji, Dr. Kesh Gupta, Dr. Radhika, Dr. Anil, and Major General Dr. Atul, and so is Dr. Rajshekhar ji. So we have touched most of the point. I have few being on the perspective of a cornea surgeon. So when you see a state like Punjab, though we are very efficient to work, and we are in fact, I would say this is not a eye donation, it's a more important eye transplantation, on which the Punjab, Dr. Rakesh Gupta and the team worked upon to make this 5 district of the Punjab corneal bilateral blindness eradication program. So if you talk of the eye donation, the hitch at the every state level is the registration at director level. So if those hitches are gone, the surgeon, they are convenient and timely, they can perform the transplantation. So first step, I would say the registration of like DRME should be institute friendly rather than ordering. And registration should not be against one name, like any hospital, say any government sector, you have 5 people operating for the surgery. Is it visible there?
Yes, it is visible, but
Okay.
can you move the slide, please?
I'll do it. Registration should be not against one person. Say we have a 5 person in any institution. Say if one person has been transferred to some other place, the eye bank would stop functioning. It should not be there. Delayed in re-registration should not be it should be an automatic system to give an extension till that renewal is done. What my suggestion is, all airlines should be approached for giving a help to us. Government sector has certain restraints and limitations which we should look into their high caps, and we should address all those. Sitting here, we have guidelines, we have process to go on, but actually when you work in a government sector or a private sector, they have a certain high caps which can be checked individually and seeing them. If we talk of the incentives, like any cornea transplant center is paid around 7,500 for any cornea transplant. And the cornea to that center would cost around 8,000, maybe 10,000. So incentive at different level has to be looked into. So to promote more cornea transplant to eradicate the corneal blindness, which is the only way of eradicating the blindness, is the transplantation. If we would not assist transplantation, facilitate transplantation, it would not help even have enough donations. So what I would say, the safety of surgeon is the most important. Many cornea surgeons, they would not do because of the procurement, hitches in the procurement and distribution of the system. I would personally say, let's have some system like a central distribution system we have from EBI in Delhi, which is the third party that would distribute the tissue to the corneal surgeon, and corneal surgeon have nothing to do with the eye banking and procurement of the tissue. Another thing is the proposal said there should be a bar of 100 transplant per year. That's not possible because that doesn't depend upon the surgeon, it depends upon the availability. I would say the government sector, I believe, should collaborate with NGO like Eyesight, Sight Savers. They have a better system of procuring and delivering the eye banking system. And to promote more cornea ablation, all hospitals, say government hospital and multi-specialty hospital, we should have a must HRCP program there. Regarding registry, I would say we have to involve our team at the civil surgeon level. At civil surgeon level, we can individually reach to each block and each village to register the blindness people, whether it's uniocular or bilateral blindness, and the extent of blindness, then we can address. So similarly, sometime back, there was an issue in Punjab state. They didn't have a NPCB funds for cornea transplant to be paid to state of government Punjab last year. So there should be enough funds. There should be ease of delivering those funds from the center to state and from state to the respective people, those that are going to use it. Like if you know, just know Dr. Ashok has said we contribute around 40 lakh for developing an eye bank in the government sector. You see, the eye banking is the national issue. Why not in the private sector? Why can't we, collaborate with the private sectors to aid them for the eye banking and the other equipment which is needed for the eye transplantation? Not to miss is the recognition of corneal blindness, which can be preventable. We have to have certain guidelines, certain system to check what are the various causes of corneal blindness, like injury, like nutritional deficiency. We have to touch on those points. Major is the trauma. So those are my few points. And all eye bank staff like ophthalmic assistants, nurse, grief counselor, clerk, manager should be dedicated to eye banking only. Most of the places, the government sector, we pick up the people, you post them in the eye bank, but they're working somewhere else. Last but not the least, we need to look into the THOTA amendment for simplifying. Why can't we make it only a tissue transplant? And like we have an eye bank, we have a skin bank and bone bank, we can have simply corneal bank in any hospital. Why we need a THOTA for this? So these are the few patients which has been treated for cornea transplant at our center during that bilateral blindness, as I have been advised to share. So see, a bilateral patient, when it comes to you after a year with his good vision, that would really encourage you to make more efforts and make this world corneal blindness free. Thank you.
Thank you, Dr. Shakeen, for your wonderful presentation and wonderful cases, the difficult cases you did in your center. So thanks a lot, and thanks a lot for being brief and for the very valid suggestions. And these will be incorporated in the recommendations. I share it with you, and you can add those recommendations as required. So thanks a lot.
Thank you.
So over to Mr. Arun Verma.
Thank you, Dr. Rakesh, and thank you, Dr. Shakeen. Sorry, I apologize to Dr. Rakesh Sharma ji, who is a director with the Cornea Center, that we have to make little changes in the agenda because Dr. Shakeen has to go. So now our next expert is Dr. Ashok Sharma. He'll be giving on the report of the Center 23-24 difficult cases of keratoplasty performed in the center. So Dr. Ashok Sharma Director is a well-known doctor in the Cornea Center Chandigarh. He is a former associate professor of the PGMR Chandigarh. He is a cornea fellowship. He is LBPI Hyderabad 1994, eye consultant of Maryland, USA 1996. He has published more than 100 research papers in the peer-reviewed national and international journals. As far as the awards, it's American Academy AO Achievement Award for 2009, AO International Ophthalmology Education Award 2013, AO International Scholar Award 2013, and AO Best Poster Pediatric Corneal Transplant 2015. The Best Paper Award for SSI Conference for the FIVRIN Glue 1998, Dry Eye in JRA at National Conference 2000, and Chemical Eye Injury by WHSR Conference Nepal 1998. Himachal Pradesh State Award for the Contribution in Surgery 2009, Cornea Hero Award Chandigarh 2020. He is a very popular cornea surgeon in Chandigarh. So now I'll over to Dr. Rakesh, Dr. Ashok Sharma.
Yeah, Dr. Ashok, you can share your presentation when you have been made co-host. Yes, your slides are visible. Just make it in a slideshow mode.
Now I guess.
Yeah, it is visible. Yeah. Yeah, from the beginning. Yeah. Yeah. Thank you. Thank you. It's visible now.
Good afternoon, everybody. At the outset, I would like to thank Dr. Rakesh Gupta for making me part of this program, and also the recommendations which has already been sent to Dr. Rakesh Gupta. Involved in corneal transplant ever since I completed my residency, and that's way back in 1988. And there used to be a big problem for corneal transplants. Number used to be very less, and we formed Eye Bank Society in Chandigarh to promote the donations, enhance the number of donations, and we could do that through the society. And by the time I left PGI in 2002, at the level of associate professor, we were able to perform around 250 corneal transplants in PGI. When I started in practice, it used to be a big problem because in private we don't get corneas, so we persuaded many people. We started our eye bank also initially, and we procured corneas for about 10 years, but then we discontinued because of the huge expenditure and all that. Blindness is the biggest curse on the mankind, and blindness is horrifying. This can be, we can have experience by closing the eye. The only person who was totally blind from the birth and could motivate all of us to do better in this area is Helen Keller. And she said that only thing worse than the blindness is that those who are not seeing despite having their eyesight. So globally, to take care of the blindness, we have Vision 22, and the baseline is that every human has right to see. And this program has been launched, and this take care of avoidable blindness, visual impairment, including cataract and all that. So eye care delivery system is a basically pyramid, and we need the a center of excellence, and then tertiary care centers. But then we need so many other areas like vision. So as to take care of the preventable blindness. When we look at the blindness as whole, we have countries like South Africa where the blindness is more, but the facilities for the eye bank facilities are very less. Fortunately for us in India, we are doing much better. And we will be surprised to know that 55% of all the corneas who have been procured, they have been procured in United States and India. There are so many conditions which causes blindness. In our country, in developing countries, most of the times it's the preventable causes like corneal infections, injuries, corneal edema, and then nutritional deficiencies. Whereas in the Western countries, developed countries, the corneal degenerations and dystrophies which are more often seen. Whatever is the cause of corneal blindness, the answer is only one, and that is corneal transplant. It's a miracle surgery, but it's only possible if we can do good corneal graft, and that is possible with the good eye donation. These are our statistics. We have been able to touch the figure of 100, which is advisable to most of the trained corneal surgeons in all these years. Even during the like COVID epidemic, we were able to perform around 100 corneal transplants. Ours is a dedicated center. We do corneal transplants for anyone who comes to us, even if he's poor and is not able to afford, we do corneal transplant. This young man was brought to us from Sector 17 bus stand. We did corneal transplant for him. And this is now more than 24 years that he's seeing 6x with this eye, and he has not to worry about his charges and all that. This gentleman was brought to us in 2003, and his son said that just do something for him, because one eye was blind due to glaucoma, the otherwise was blind due to corneal opacity. Otherwise, he would die because he has made 3 attempts to finish his life and suicide by jumping into Nangal Hydal channel. We did corneal transplants, and it's more than 25 years he's seeing with this eye. Now, this is important that I would emphasize on the quality of the corneal transplants and the quality issue on the donor corneas, because numbers are important, but quality is more important. And sometimes people are fortunate, they have other handicaps, but their eyesight is good, so they are able to earn their livelihood. And those who are blind with the both eyes, they are not that fortunate. The problem with the corneal blindness is that it occurs early in the life, and you have you are deprived of the vocational and educational opportunities, and it's very difficult to then make both ends meet. So we do transplant for anybody who is needy without charges. Also, we do it. Numbers, as I said, it's important, but we need to focus on the quality also. There are several issues which are in the quality, but I would advise that all those who are involved in the eye banking, they should follow the standard protocols. We have seen few eye banks where the standards were not followed, and fortunately they have to be closed. So all those standard protocols, they should be followed, so that we get quality donor corneas. I think the specular microscopy is more important to assess the donor cornea. Unless we assess the donor cornea, we will not be able to get the desired result, because we will not be knowing how good is the donor cornea, and how whether we will be able to use it for therapeutic purpose or for the optical purpose. As it has been highlighted very aptly, government, non-government, and charitable, all and corporate enterprises, they all need to be act in a coordinated manner. So we need inputs from all the sides, so that we are able to perform better. In addition to adults, these are the young children, and they too need corneal transplants, but they are being overlooked because the transplanting children is a very difficult issue, and we have been doing it since we started corneal transplant. And this is one example. This is a child born with both eyes microcornea, microophthalmia, sclerocornea, and one eye was operated in 2017, other eye was operated in 2018 at a very young age of 5.5 months and 7 months. And now this child is going to school and is enjoying all activities like her classmates. So it gives immense satisfaction if you are able to do rehabilitation, visual rehabilitation for this kind of people. Another very difficult patients are those who have Down syndrome. They have very high incidence of keratoconus, and once they present, they have very advanced keratoconus. I'm showing you two pictures of two. And then these were blind when they came. When we transplanted, they are able to do all normal activities. But of course, we have to give them quality donor corneas because sometimes they may get injured. And one of my patients whom I transplanted in 2008, he had an injury and it was repaired. Then he developed cataract, and his cataract surgery was done, and still the graft is clear. So you have to give cornea to the children with a good reserve of endothelial cells so that it can survive the graft rejection or any other insult which the patient may suffer. This is one patient who is very complicated. You name any complication and he has bilateral focus, bilateral cataract, bilateral anti-uveitis, gross peripheral anti-synechiae, gross posterior synechiae, ring synechiae. There was a thick pupillary membrane with vascularization, operated glaucoma, large overhanging bleb you can see, and bleb recession with AMT has been done so many times. So we did, he was from retired colonel from army, and we did corneal transplant with him with very good corneas. Of course, he was very happy. He had 6/6 vision. We operated the other eye also with very good result. So quality issue is a big issue and big boon if we do corneal transplants. This is a lady who was blind from both the eyes. She had rheumatoid arthritis. She has dry eyes, both eyes, severe dry eyes, and deaf and dumb. So you see, corneal transplant conventional, that is a penetrating keratoplasty, would not be possible for her because the moment we do, the cornea will melt and the sutures will give infection to her. So we, under general anesthesia, we performed endothelial keratoplasty for her, and you can see the graft is clear and she could see and she is enjoying her life. So we have to take care of the patients and we have to tailor the surgical procedure also according to the need of the patient. To enhance the quality of the donor corneas, I think this is one program which is needed. Professor Radhika Tandon emphasized that very well, and subsequent speakers also. We need a good grief counselor. And of course, he needs information inputs from the hospital staff that there is some death which has occurred so that he can counsel and then he can get the eyes. We don't have the facility of fully presumed consent law like in USA, in Maryland, that any death in the institute is go and procure the donor cornea. And only thing you need is that there should not be a written written application from the family that you please do not retrieve the eyes. So that kind of situation is not here. So we have to always seek the consent. Even if the person has already pledged it, we have to have the proper consent. But this can give you very good quality of the donor corneas, and it can enhance the results also. Dr. Radhika Tandon also talked about the use of multiple patients from one donor cornea. Yes, they have reported. This is the same article she showed. And we have also used in multiple patients one cornea. In addition to that, the rim which is left, Dr. Rajan, my son, has cultured the corneal exosomes and limbus stem cells from these corneas, and that can be kept and they can be like the cellular line can be used to benefit the many number of patients. So one important thing is that eye banking and the corneal grafting, we need to stick to the ethical issues. And I talked about the consent. We need proper records also. And one thing which which I've experienced once is that we need to keep the secrecy between the donor and the recipient, because it was in, I think, 2001, before I left PGI, one mother of the donor, she repeatedly came to me and tell me to whom you transplanted the eyes of my son. I want to meet the family. He's my son. I want. So that kind of emotional problems can be there. So the proper secrecy should be there once we do that kind of thing. In case of COVID epidemics, like that situations, we need preserved cornea. We always use glycerin preserved corneas. But gamma irradiated corneas is another option. I think I have not written that in the recommendations, but this paper has been published in Hope Journal of Ophthalmology, where we have used gamma irradiated donor corneas as well as scleral tissue. And this can be very useful method of preservation, because in this condition you can keep the tissue at the room temperature. You don't even require 4 degrees centigrade. So I think we can add this as a newer recommendation. And this journal is being published from L.V. Prasad Institute only, so they can take it further, this thing. Our efforts have been appreciated, and we have got certain awards also in this area. Our poster was appreciated in American Academy, where we presented data of 250 children who had undergone corneal transplants. We continue to help the recipients, and Professor V.S. Nankari from USA, he has been always a motivating force for us, and whenever he is free, he visits us, and we are able to do. This is one thing which is very important, and we did very early when we started Eye Bank Society in Chandigarh, and that is to honor the families of the eye donors. I think Dr. Rakesh Gupta would agree with me. We have done with him, and his family has donated so many times to the PGI, to us also, and that is important to honor the family members or honor the donors on the occasions. And response time is very important for the eye banks. Once there is a call, they should respond immediately, and they should keep the contact person in touch, and they should tell them that we are coming or how much time we are taking, so that the family who wants to donate the eyes is not distressed, because at that time there is a lot of distress in the family. They have to make a lot of other arrangements also. We have been celebrating eye donation fortnight every year. This year also we did. This is the last year's photographs. And I thank Dr. Rakesh Gupta once again, because whenever we have this program, he does spare time to participate in this program. So with this, I end my presentation. I again thank Dr. Rakesh Gupta and Sipher and other organizations for giving me opportunity to share my thoughts. Thank you so much, Dr. Rakesh.
Thanks a lot, Dr. Ashok. You can stop sharing your slides. So he shared his beautiful cases, though they were difficult cases. And I may tell you that he's a very accomplished cornea surgeon in the region and has done a commendable job as a cornea surgeon. And he has been recognized nationally as well as internationally. And now, Dr. Ashok, I'll share the draft recommendations again, and then you can just put down whatever suggestions you have. So I'll now like to acknowledge the presence of Mr. Surinder from Muxar, Mr. Manoj Ohri, Mr. Behal. They have been doing a commendable job, and they have been collaborating with us for the Punjab initiative. And Dr. Kamakhya, he has given excellent recommendations. So over to Mr. Verma, please.
Thank you so much, Dr. Rakesh, and thank you all the experts for a very wonderful presentation this afternoon. So now I'll request Dr. Ashida to brief the whole today's online presentation and propose a vote of thanks to everyone.
Thank you. Thank you so much, sir. Good afternoon, everyone. It gives me a great pleasure to deliver the vote of thanks at the conclusion of this enlightening consultation. First and foremost, I would like to express my deepest gratitude to our esteemed chief guest, Major General Professor Atul Kotwal sir, our keynote speaker, Professor Dr. Radhika Tandon, and a guest of honor, Dr. Anil Kumar. I would also like to extend a huge thanks to our speakers, Professor Dr. V. Rajshekhar, Dr. Ashok Sharma, and Professor Dr. Shakeen Singh for sharing their invaluable knowledge and insights on this topic. Your contributions have truly enriched our understanding and inspired us to take actionable steps. I would like to thank Mr. Arun Verma, Director Operations and Finance Sipher, and Dr. Rakesh Gupta sir, President Sipher, for moderating this session and giving me this opportunity. Your tireless efforts in planning and executing this event has been the backbone of this session, and your dedication is truly appreciated. I would also like to thank Dr. Sanchika from ECHO India for extending their support to Sipher and making this session possible. Mr. Manoj, Mr. Bhal, and Mr. Surinder and Dr. Kamakya, thank you for joining us for this session. Finally, I would like to thank all the other participants who keenly joined us, and we hope that you will carry forward the knowledge gained and implement it in your respective fields. Now, I would request all the participants to kindly start their videos as we will having a quick snapshot.
Yeah, please, you are requested to please open up your videos. So, Mr. Surinder, I can see your hand, but we can have your recommendations written if you have anything to add. Thank you. So please keep your videos on so that we can have snapshots. Can all please switch on your videos? So thank you. Thank you, Ashwita.
Thank you, sir. Thank you so much.
So I think we need to close. We are already late by 22 minutes. Thank you.
It's okay. Thank you so much.
Thank you, sir. Thank you very much.
Thank you. Thank you. Thank you.
Very
Thanks a lot.
knowledgeable.